In our last video, we saw how we manage an intervention of meniscal repair by suture in operating room. Today, instead, we'll face another surgical topic about meniscal surgery, that is the partial meniscectomy. It is the removal of a torn piece of meniscus by arthroscopy, both on the medial one and on the lateral one. Good morning, everybody. I'm Stefano Teramo, and this is Autostrike. We note that meniscal tears may affect both the medial meniscus or the lateral one, and depending from a variety of features, it could be treated by suture, as we saw in our last video. You find the link to this video attached in the description. On the other side, when the meniscal tear is located in the wide zone of the meniscus, or when the quality of the meniscus is poor and it's characterized by a strong degenerative pattern, it may be worth to proceed with a partial meniscectomy. In these cases, we orthopedic surgeons must try to be the most careful we can, because we have to try to remove the minimum portion of meniscal possible in order to fix the mechanical symptomatology, but at the same time to save as much residual meniscus as we can. So, as we said, it's worth to try to avoid partial meniscectomy when possible. Unfortunately, not always it's technically possible to perform a meniscal suture, so in some specific case where is present a strong mechanical symptomatology or painful limitation for the function and the quality of life of the patient, it's worth to proceed with the surgery of removal of the torn piece of the meniscus. Now, let's give a direct look to how we perform this intervention with our surgical images. So let's start with the arthroscopic assessment of this meniscal tear. Is the meniscal lesion located in the posterior horn of the lateral meniscus. In this case, we have a traumatic tear with a good tissue quality, but unfortunately, it's an obliquous lesion that is completely located in the wide zone. So the prognostic in case of suture will be really poor, and we decide to go on with partial meniscectomy. In this case, we use this instrument called basket, which is the possibility to fragment and progressively to reduce the volume of our meniscal torn segment. Let's turn just for a moment our attention of the arthroscopic portals. We said in our last video that usually we use the anterolateral one in order to put inside our camera and the anteromedial one in order to operate with the instrument. But in this case, we cannot, that it is not a good idea, because the angle of incidence of our surgical tool, in this case the basket, is not good and has the tangent incidence of meniscal tear and doesn't allow us to have an efficient action of the meniscal torn piece. So in this case, it's crucial to proceed with an inversion of the portals and to introduce our surgical tool, in this case the basket, through the anterolateral portal. This provides us a better angle of the meniscal torn piece and a more efficient action. To go on with our partial meniscectomy by alternating the action of the basket with the action of the shaver, of the motorized tool that not only sections the small fragments proceeding by the action of the basket, but also regularized and makes smoother the meniscal residual surface and allows us to get a smooth and regular and above all stable residual part of our posterior segment of the lateral meniscus. Then we introduce our probe in order to assess and confirm the stability and regularity of our result. As we can see, there is not anymore any unstable fragment on the posterior horn of lateral meniscus. We just saw the example of a traumatic tear of the posterior horn of the lateral meniscus. Now let's turn our attention of another kind of lesion. This is the degenerative flap lesion on the posterior aspect of the medial meniscus. In fact, we insert our arthroscope and we assess the quite degenerative aspect of the medial compartment with a mild chondropathy at the medial femoral condyle. In this case, we have grade 2, 3 of chondropathy. Furthermore, we'll have the opportunity to analyze in detail the classification in grades of the chondropathies in some dedicated video, but now what we see at this level is a mild chondropathy, and in this previous context we may assess the presence of a degenerative tear of the posterior horn of medial meniscus that presents a flat and unstable segment that goes making an impingement between the femur and the tibial, the posterior region of the knee, and may provoke not only painful symptomatology, but also occasional joint blocking with a limitation, painful limitation of the last grades of range of motion, both in extension or in flexion. We have to say that this blocking symptomatology may not be constant because it depends from the present localization of the segment that may be sometimes reduced and less symptomatic, and in other cases to displace anteriorly and to provoke more intense symptomatology and mechanical blocking. Thus, we proceed with our partial meniscectomy by alternating the action of the bascule and of the shaver and progressively reducing the volume of our meniscal flap. The final goal of our actions will be to eliminate the presence of an unstable fragment of the meniscus and to restore a regular residual surface on the posterior aspect of the medial meniscus. In this case, our residual meniscus will have necessarily some persistent small irregularity due to the degenerative nature of these lesions and to the mild osteoarthritis context of the medial compartment. But the most important goal will be to reach stability of the posterior horn and no more unstable fragments able to produce mechanical interference between femur and tibia, as we are able to confirm by inserting once more our metallic probe in order to confirm the stability of the residual portion of the medial meniscus. In cases like these, where we have an evident degenerative progress on the cartilage, it's sometimes helpful to try for a little help for the joint by viscosupplementation. It does the lubrication of the joint cavity by injecting into the joint some natural lubricants such as collagen or hyaluronic acid. It's not, of course, a definitive treatment, but is something that may help relieve, at least during the period, the symptomatology related with the degeneration of the cartilage surface of the joint. And it's easy to perform at the end of our procedure by inserting a needle into the joint and injecting our collagen or hyaluronic acid into the compartment affected by chondropathy. It's just one of the complementary actions we will see in detail in the future that we may apply on our joint in order to prevent the evolution of the degenerative symptomatology and to relieve the clinical consequences of mild osteoarthritis. Postoperative recovery after a partial meniscectomy is quite quicker than the one we saw in the previous video about meniscal suture. You find a link to this video attached below in the description. In fact, in case of partial meniscectomy, the weight bearing is allowed from the day one. The patient is discharged after surgery with a full possibility to charge his body weight of the operated limb with the help of a couple of crutches, but just in order to recover the stability and confidence by gait pattern until the relief of the inflammatory symptoms of the first days post-op. But in fact, it's a full and immediate weight bearing on the operated limb that is a right crucial difference in the recovery if we compare with the one the meniscal suture. The first weeks after surgery will be dedicated to rehabilitation protocol that will have its final step in the return to play and to sports activity in more or less 1 month since surgery in case of medial partial meniscectomy. Whilst on the lateral meniscus, the post-op recovery is normally slightly longer because we approximately need 1 month and a half, 6 weeks in order to have a progressive return to play. From a rehabilitation point of view, we also see in this case the crucial aspect of the muscle strengthening process in order to provide the created joint more efficient neuromuscular control and higher stability that helps to reduce the negative consequences over the cartilage surface that we can't avoid to have in the future after a partial meniscectomy. So that's all about partial meniscectomy surgery. I thank you for your attention once more and see you on the next Arthroscopy video. Thanks a lot and bye bye.
Come along with me, loving me too, waiting for long tree. I'm waiting for you. There is no choice. Nobody cries too long for me. Sometimes I fall and rise, you know. Some people fly so far with you.